Hello everyone. So this video is about Wolff-Parkinson-White syndrome, also known as WPW syndrome. The syndrome is characterized by an accessory pathway that connects our atria to the ventricle. A normal atrial impulse leading to a ventricular contraction starts from an AV-SA node. This SA nodal impulse then travels and reaches AV node, which after an AV nodal delay of 0.1 second goes to the bundle of His and then through the right bundle branch and left bundle branch causes the ventricular depolarization. This is how a normal pathway works with an AV nodal delay. What actually happens in WPW syndrome is we have an accessory pathway bundle of Kent. The location of bundle of Kent most commonly is between the left atrium and left ventricular free wall. So this is the location if this is the left side. This bundle of Kent makes the impulse travel from atria to the ventricle without any AV nodal delay. So with no delay, there will be pre-excitation of the ventricle. This pre-excitation of the ventricle will cause ventricular contraction. After an AV nodal delay, the impulse will also pass through AV node, and by this normal pathway, the ventricle will also contract with an AV nodal delay. So, already existing ventricular contraction will be prolonged because of the impulse reaching via the normal pathway. So, in WPW syndrome, because of an accessory pathway, we have pre-excitation of ventricle, and then there is further prolongation of the ventricular contraction because of normal pathway impulse reaching the ventricle. This is the pathophysiology behind WPW syndrome. Let's talk about ECG changes. So this is an ECG schematic diagram. We see this P wave, and as the P wave finishes, we have the without any PR interval, means no AV nodal delay, we have ventricular depolarization starting. This ventricular depolarization is slurring and slowing upstrokes. Okay, we see this slurring and sloping, means we see that slow there are notches in between, and these are what are known as delta waves. And after this delta wave we have ST segment, okay, and then the T wave. These ST segment and T wave may show ST-T segment changes, okay, which may include ST elevation sometimes. These are the ECG changes. So the first ECG change is no PR interval. We have, because of AV nodal delay is not present. Then slowing and slurring of the slowing and notching of the upstroke of the QRS complex is known as delta waves, and STT segment changes will be seen. We have some ECGs now. This is the first one. We see a P wave and then the Q upstroke without any PR interval, and this Q upstroke is showing some notching and slowing. And this is another image showing the shortened PR interval as well as the delta wave that is notching seen in the V3 lead. T segment changes will be seen. Treatment include catheter ablation, which is a treatment of choice. You see in this image we reach through the inferior vena cava or the superior vena cava up to the heart, and then in the heart we ablate this abnormal tract. The drug of choice for a hemodynamically stable patient of WPW syndrome is an antiarrhythmic IV procainamide. These slow the conduction through the tract. Okay, DC cardioversion is used in hemodynamically unstable patient. The antiarrhythmic drug, okay, these like procainamide, disopyramide, flecainide, these work by slowing conduction in the accessory pathway. And how so? They prolong the refractory period. So this is the use of antiarrhythmic. So these were bits about WPW. We'll continue clinical features in next video. Hope you liked it. Thanks for watching.